Hello, I'm Dr. Alan Malik, and welcome to this fourth and final webinar in our series on how to boost your integrated behavioral health program performance. In this webinar, we're going to get into screening in your clinic. In the first webinar, basically we came back to realizing that there's an awful lot of information that you can gather to the point of you need to think about screening as more like a patient interview. And it does great things in terms of improving the performance of your program. And so, doing that interview, you basically have to get into electronic assessment is really what it comes down to. So you kind of have to make that jump over from the manual paper world over to electronic. But it's actually very easy to do, and in the long run, you end up saving time and money. So, you're really simplifying your whole process by getting much greater depth of information. And so then in the third webinar, we kind of went through, how do you make the business case for that? And you kind of want to look at that from CJ Peek's three-world view of clinical, operational, and financial. But, you can put that case together in a format that leadership's going to understand and be able to get behind. And so finally, in this fourth one, we're going to look at, what are the nits? What's that really going to look like? What is it really going to take to do this inside of your program? And so let's get into it. So, we need to start just really what it comes down to is there's just lots of options and lots of capability available to you. So we just kind of have to work our way through what are those screening protocols that you're going to get into and what's that breadth of information that you're going to be working on. And then you need to think about your level of automation and equipment requirements. We strongly suggest that you start screening directly and doing kind of like manual data entry, which is basically what you're doing now with your EMR integration, and then actually come up with an EMR integration plan. And then we need to think about problems of potentially training and support, which actually turn out to be very minimal. And then, ultimately you're going to want to implement in phases, and we'll talk to that whole thing. And just think of it as a project. It's going to take some time to get it in place, but they're easy steps, easily digestible, and so forth. So let's get into it. But the big thing here is that all this stuff is sitting in apps, and so it really comes down to download and implement. Just build out. It's not. The implementation process has been dramatically simplified. So let's think about screening protocols. And, the typical sort of ones are your age-based detection. So you're looking for like well-child visits and annual visits. So you're getting into all the guidelines, the AAP guidelines of 3 developmental screenings by age 3 and 2 autism screenings in the second year. And then you need to start looking for behavioral issues down to age 1. Those are all AAP sort of things. And then as you get a little bit older, get out of age 5, then you start getting into, actually by the time you get towards adolescence, you start getting into guidelines that say, hey, you need to be looking for depression, major depression through adolescence and out into adult. And then, in terms of looking for that major depression, essentially like the postpartum sort of depression is a big area that you need to be getting into. And you need to be looking at that at the same time you're looking at the child for their developmental delays and so forth. So there's a whole bunch of stuff going on just basically well-child, annual checkups, age-based sort of detection issues. And then, if you're going to get into programs where you're looking at, say, maybe your treatment of chemical dependency, or your treatment for workers' comp and so forth, you find that you start getting more episode-based. And so, essentially, if you can come up with something that is episode-based, then you can go that route. Then then your last area is just, most of the time when you hit chronic disease, you just want to monitor. So you're basically monitoring continuously and so forth. And so it's like one big long episode, but it's the same concept. And then, from the basic sort of stuff, you need to think about this in-depth assessment, and is it going to be triggered or on demand? And so in some environments, you just kind of do your basic sort of assessments and so forth, and maybe you queue up the in-depth thing as you need it. In an ideal situation, you use your PHQ-9 as a pre-screen to automatically trigger some in-depth information. And then you have all that automatically done for you before somebody gets in front of you. And there's all sorts of advantages because now you can hand that off to a provider, medical provider, who can understand what you're doing, and then they can use that to communicate across for the warm handoff and the brief intervention and so forth. So anyway, there's this whole process of just figuring out what you want to be doing. You got to get all those pieces in place and think about the different people you're going to have involved and the types of information you need for each one of them. And the broader that you get with that, the better the impact you're going to have on the process. So then your next level is just the level of automation. I mean, and this really does come down to, are you going to be using tablets in the office only? And are you going to launch from the tablet? Which we have people doing that for years and years and years. I mean, even the Kaiser here in Colorado, we never ended up doing any sort of launch other than enter your Kaiser ID. There's actually an internal code, redundancy code inside their IDs that you can actually check and make sure that they're valid and so forth. But you end up with just one, they enter an ID, everybody knows their Kaiser ID, and they're off and running. And the protocol is automatic, depending on where they're at in terms of what tablets are picking up at what clinic inside the organization. But then you can move up from there. You can go to front desk sort of applications on PCs. And then, eventually you're going to want to have that launch coming from your EMR. But, that really is kind of a second level sort of thing. But that whole automating the launch side of this thing is a big deal. And then, where are you going to administer? Are we going to be doing this in the office? Are we going to be doing it at home? We're going to do some combination in between the two. And then when the data comes back in, I mean, that's always the question of, well, where do you want it routed to? And what we typically see is it's kind of it's a split. You end up doing that summary note, with things that are out of range and basic information that you need, kind of goes into that encounter tab usually. And then you end up with the PDF of the report goes into your documents folder. And then all your data fields go off into your data warehouse. And the data warehouse doesn't have to be anything elaborate. I mean, you can just even put it in a Access database, or, ideally you want to have it a little more secure so you don't actually want to run it up into a SQL somewhere inside your system. But, if you run every single data record in there, then you have every single keystroke and every single computation that's been done is available to you in your warehouse. And then, some groups are actually more into the health information exchanges and so forth. We find that, like when we're doing social determinants of health, there's usually, you want to go through an HIE because they're hooked up to community resources and so forth. So it just kind of depends on the environment you're in, where you're going to route data. But the whole idea here is that we use a data exchange that can route it anywhere you want. You can have multiple transactions going to multiple places. And so you kind of need to just think through, okay, how automated are we going to get? I mean, you can start out with literally just one tablet. Go get a Kindle Fire. Actually, I wouldn't recommend a Kindle Fire because it doesn't communicate that well. But it actually works fine, if you want to go home visiting or whatever. But probably an Android tablet, like a Galaxy Tab or something like that, or just iPads. And, you're up and running inside of an office setting. So, equipment requirements. So, what you need to figure out, for this sort of thing is it comes down to, what do you think your annual volume is going to be? And then you got to figure out where it's going to be at. So, really, how many screenings are you going to be doing? And then, how many are going to be done in the office? How many are going to be done through remote? And so of those in the office, then you got to start breaking those down. So, just an easy way to calculate all that is to sit back and say, well, there's a couple thousand hours in a year. So if I'm only doing one an hour, which is like way low, I can do a couple thousand out of my annual pocket with one tablet. More reasonably, you would say 2 an hour, so one every half hour. So you can do 4,000 annually with a single tablet. And it's not unreasonable, especially if you start getting a little volumes up a little bit. People are going to easily finish these things in 20 minutes. So you can actually, if you're cycling them through, you can do upwards of 6,000 administrations per year with a single tablet. So, just kind of where you're at with those. But, you're going to need at least one if you're going to be doing stuff in the office. And you might consider maybe doing, like an extra one for peak flow sort of situations and so forth. But the reality is that you kind of flow at a given rate because you can only push them through the docks, through through the providers that you have there at a certain rate too. So, you know, it is kind of limited by that process. And then, you know, you go to the portal sort of situation, you can shoot any volume that you want through there, and obviously that pushes its way through as well. So, and then just a little guidance on tablets. I mean, like I say, the higher dollar sort of thing are the iPads. They're usually a little better quality, but you can get a great tablet like a Galaxy Tab or Lenovo and so forth, are all Android sort of tablets that work quite well, and we see them in a lot of places. And then we even have people using Kindle Fires. I mean, you can use a little $50 Kindle Fire 7-incher, and they actually have quad-core processors in them, and they fly through the questionnaires. They actually work great. They're just a little flaky on their wireless chips and so forth. So when you're moving between zones and so forth, you have a little problem getting those to keep connected. So, you know, the yins and yangs in each one of them. But, you know, it usually, you know, in the early days, we were always worried about people were going to run off with the tablets and so forth. You don't see that at all. And if you really are worried about that, then go get some Kindle Fires and you know, $50. I mean, you know, how much trouble can you get in with that? So then, you know, we need to think about this EMR integration. Like we say, you should really push this off to a phase 2 sort of thing. But you really need to think about that as a project. And, you know, it can be really simple, but in most cases it's not. So just to warn you ahead of time. So kind of the major steps that you're going to need to go through for that, to just give you set an expectation, is first thing you have to do is engage your IT department. So, you know, the things that they're going to be worried about is access and security, you know, your HIPAA and all that kind of stuff. And so it's usually pretty easy to get through that sort of thing and get those guys under, you know, into the wagon and so forth with you. And then, you know, once you get IT to be able to get the information to flow, then you have to talk to your EMR integration team, so the interface team. And so we get into this concept of getting the scheduling feed and the lab report going back in. But if you've already got your data storage set up inside your system as to where that's going to go, you know, that's the big problem with this whole thing. Those interfaces actually become quite easy, because all you're really saying is define one message going in and one message going out, and what you're going to put in those fields, which is actually really simple to do. Each side basically takes a test message. They set up their interfaces to do it, and then you do an end-to-end between the two groups, and you're up and running. And so once you get past that problem of where you're going to put the data, the rest of the process is actually really easy. And so, you know, the reality is right now you're already doing that. I mean, anybody who thinks that they're actually integrated in their EMR, what they've done is they've gone through and figured out how to store your PHQ-9 scores or whatever, and you've turned around and actually created forms internally, but now you're doing manual entry from there on in. You're either manually entering the data, and if you happen to have calculation capability, then it automatically calcs it for you. If not, you're actually you're most likely using paper. You're running that up, calculating it manually, and then you're taking the score and entering it. So even if you had a tablet and all you did is have the report show up on the tablet after you got through with the administration, go through a little access code and do it, you'd have all your scores sitting there, and you're going to do your manual entry anyway. It just did the calculation for you. So, you know, the concept of integrating needs to really be split into two parts. There's the actual movement of the data, which is actually the piece that you need IT for, and you do need to get on a list with them and do the little project sort of thing, which it's not difficult, and it's, you know, once you commit to doing that, it's an easy sort of thing. The real problem becomes one of getting the data storage set up so that you can actually run it in and access that information through your forms inside of your EMR. And that process usually involves a lot of people and a lot of negotiation, and that's the real hang up. But the reality is you're already doing that if you think that you're doing EMR integration right now. And the real difference between what we're saying is have your patients do your data entry for you, don't have your staff do it for you. And, you know, that's a minor distinction. And then you turn around, and once you stop doing the staff entered, put it out to the patient, put some intelligence behind what you're doing, some ability to be dynamic with that questionnaire. Now you can expand it out to a full patient interview. And so you really want to be careful how you think about that integration. But EMR integration electronically is a whole lot better way to go, and it's going to save you a whole lot more time and money. So then training and support. Usually most of the stuff is, all we're really worried about is like in-service sort of thing. So if you've got this down to all staff has to do is pick up a tablet, enter an access code, click on a launch item, not much training involved with that. If you start getting into the patient management sort of things at the front desk, and those will kind of break out depending on what you're trying to do, whether you're doing outcomes or registry or whatever. But it's really pretty simple. And so most of the stuff at this point, we'll either do it in person through webinars, but we're even getting to the point where most people are just really, you have some YouTube training set up and people access that. And then you can break that down into, little digestible chunks so you can go, oh, I need this specific thing that I want to do. What's my 1 minute or 2 minute little YouTube that'll actually solve that problem for me? So training and then support, obviously tech support, that's kind of what, all comes for free in terms of the capabilities and when you do that per administration sort of pricing model that we use. So, now it comes down to implementation. I mean, there really aren't too many roadblocks in terms of getting to that point. But when you implement, you really want to do it, you want to start out, say, in a pilot sort of situation, find some people that are a little innovative that really want to get to the more in-depth information. They're willing to try changing their processes a little bit and get them to, start the screening process. But don't fight the EMR battle immediately. The reality is you can go out and get that screening implementation to work first and we're actually starting to have the conversations around your EMR. Because the EMR is going to take some time to get through all the approval process and so forth. So, you can actually start phase 1 and phase 2 at the same time, but the reality is you'll implement phase 1 first and then get to phase 2. And what we're seeing on phase 3, which is our typical phase 3, is when you go to the remote portal sort of thing. I mean, we can pass those links in that you can pass out through your secure email inside your patient portal, but what we're seeing with a lot of organizations is they can't get people to use the patient portal properly. And they can't get them to use any portal properly is really what it comes down to. And so what they're finding is, a link. And we used to think that it was email was the best way to get that link out there. But what we're really seeing now is just a text. You basically, if you want somebody to respond to you, you send them a text and here comes your results. It's kind of interesting. I mean, so, in this more modern world, that direct sort of SMS text link going out at a scheduled time before the visit is the most effective way to get information into the system. And along with all that, there's a couple little things you want to do on top of that. There's, you'll want to probably set up a security phrase so that every time they hit that link, the first page will say, here's your security phrase, and it's individual to them. So they can sit back and go, oh, yeah, well, it's not phishing. Somebody's not shooting me a link out, just trying to give me some information. But the other thing that you do is that when you go out to that, essentially that's a remote launch. So there's no PHI that they're going to be entering out there. It's all that has been entered inside your organization and remains inside your organization. So, you can also set the expectation with your patients that they will never ask you about, patient protected health information and so forth. So between the security phrase and lack of PHI, that direct link sort of concept to a text is turning out to be the way to get to people and get your information if you're going to do it outside the office. But, once you get them in the office, they basically have checked in at registration and it's time for them to give you the information there. They're definitely going to get it done before they see the doctor. So you can get information out of everybody. It's not that big a deal. So, when you get done with all this and you kind of laid out all these sorts of things, you really want to think about your screening plan. Just about everything that you're going to ever want to look for are already sitting in content packages in the system. So, another advantage of using the electronic formats and so forth and the apps is that all those production costs of creating all these assessments and so forth are already done for you. And so, that's part of it, makes it a whole lot easier so you can get to a full breadth of measures just using content packages. The other advantage of using not using form-based sort of things like in the EMR and so forth is that when you do that screen by screen you can put that into a mobile format. And so we have them so they're adaptive now. So when you get down on a small resolution phone and so forth, you'll cut down a couple font sizes, you can ditch your header and so forth so that you can actually keep the question on the screen properly. But those adaptive formats, question by question, we also set ours up for single click so that every single screen is a single question. Hit the button, go forward, and you're pretty much there. Then obviously you automatically pull all those protocols together so that that whole process, once you get that worked out, it happens automatically for you. You don't have to have staff thinking about that anymore. And then it's all this seamless integration. So it's really easy to get started. You can just set up an account, download some apps, do a little in-service training, and you're up and running. And then you can just expand in phases when ready. So it's not that difficult a thing. We could probably, the easiest way to go through the demos is actually there's demos on our website. There's also, we can set up pilot applications for you and so forth, so you can go try things out for a week or two and so forth and see how it goes. But it's a very simple process to set up. So anyway, basically that kind of concludes the whole process here. We're just trying to show you how you can move from your current manual, really low level of information that you're doing in your screening process over to really in-depth, automated, lower cost, far better effectiveness settings. And it's all really simple to move forward. So if you're interested in exploring further, there's a contact form below. Just send it off, and we're more than happy to work with you. Otherwise, I hope you learned about some other ways to go about solving some of the systemic problems that are out there. But anyway, there's still a long ways to go for an awful lot in this medical world. So anyway, please leave comments, and anything we can do to help, let us know. Thanks for your time.